Hi, just wanted to introduce myself. I'm Dr. Matthew Harb. Thank you for joining me for this presentation. So I want to give a special shout out to both Johns Hopkins and the Gildenhorn Institute for hosting this meeting. If you have any questions, you can place them in the Q&A section of this talk, and we'll get to them as soon as we're done the talk. So this is going to be on hip and knee arthritis and determining when you are ready for a joint replacement surgery. So let's get into it. So the first part is, what is arthritis? And I think that's kind of what we have to know to educate ourselves on this and to know exactly what we're getting into and how we can treat it. So at the very core, arthritis is destruction of the cartilage surfaces. And this can kind of present itself in a bunch of different ways. You can have it on the inside of your joint, the outside of your joint. You can have it behind the patellofemoral part of your joint. And determining where it is can determine the severity, but it can also help you know the symptoms as well. So usually when you get this cartilage destruction, your body tries to heal it. The way it does that is it creates this inflammatory reaction. This inflammatory reaction can both present as joint swelling. It can present as tenderness around the knee. You can get pain as that joint swells. The joint capsule actually gets pushed on and those nerve fibers get pushed on. And that pushing on those nerve fibers causes a lot of pain. Usually over time, it does get worse with age. The average age for a knee replacement can be anywhere from about 55 to 70 years old. People may experience a grinding sensation, a clunking, clicking, or the knee actually locking up on them. So all of these are kind of the conglomerate of symptoms that present with a arthritis type joint. So looking at these schematics, you can see on the left side of our screen, we have a normal joint. You have the nice, shiny white cartilage. You have the meniscus, which is the shock absorber in between the joint. You have the joint space, and with a healthy cartilage in the knee, you have a good joint space. As we see on the right side of the screen, when that cartilage starts to wear away, the joint space gets narrow, it collapses, the knee may fall into either a bad alignment where it falls in or falls out. You may become knock-kneed or bow-legged from the arthritic changes. As you get that cartilage loss, you also develop these bone spurs. The bone spurs is kind of a protective mechanism of your body to try and stabilize that unstable knee. And with all that, you get damage to the subchondral bone. That's the bone right underneath the cartilage. And that's where all the pain fibers are located. So really, once that cartilage wears away, you start to get the pain. So this is an X-ray. I think it's very important to have a general understanding of what an X-ray looks like for an arthritic knee, because it really shows the changes. So looking on the left side of your screen, we can see the thigh bone up top, the shin bone on the bottom, and we see where these orange arrows are pointing that nice, clean joint space. It's big, there's good cartilage in there. So the cartilage doesn't show up on the X-ray, but it shows up by this black space that's in between the knee. So looking on the right side of the screen, we can see the thigh bone and the shin bone once again. And you can see that the joint space is no longer there. So what that means is that that cartilage that was once there has completely eroded away. And in this patient, this would be a patient who presents with a knock-knee deformity, or what we would call a valgus alignment to the knee, which just means that the foot is kind of falling out and that lateral or outside compartment of the knee has worn away and the cartilage is worn away in there. The other thing you can see bone spurs on the side, and you can see that bone becoming very white. And what that means is it's very sclerotic. And as the cartilage wears away and you get bone on bone, the bone itself will remodel and become very, very hard. So on X-ray, it gets this really shiny white appearance that we can see in the outside compartment of this knee. So this is looking at a hip, which is a very similar type of circumstance. The knee is more of a hinge joint. The hip is more of a ball and socket type joint. And with the ball and socket, it's the same kind of thing. On the socket side, which is on your pelvis side, you have a nice white shiny cartilage. You have something called a labrum. The labrum in there is the shock absorber. It's very similar to the meniscus in the knee. And over time, you get destruction. And as that destruction happens, that white, shiny, smooth cartilage, which is protective of your joint space, wears away. And then you get bone-on-bone arthritis, and that subchondral bone is banging up against each other. And that's where all your pain fibers are. And that's why you get so much pain in the hip. You know, the hip arthritis can start from a bunch of different things. It can start from a previous injury, a labral injury, it can be hereditary, it can be from an autoimmune disease. So there's many different reasons why the hip arthritis will develop. But it's important to notice what kind of the signs and symptoms are of arthritis so that we can get an x-ray, work you up, determine what the cause is, and figure out what treatment's best for you. So this is the same kind of thing. It may be a little bit more difficult to appreciate on the hip x-ray, but if you look on the left side of the screen, you see a normal joint space. This is thick, healthy cartilage in there, thick, healthy labrum in there. As that cartilage and labrum tears and wears away, you get bone spurs. So looking at the right side of the screen, we can see complete joint destruction. The femoral head is flat. It's no longer spherical. It's lost that nice round shape. And so you can imagine it's like this clunky ball that's trying to articulate in a socket, and it's just clunking around in there. It's not really providing smooth motion. And that's why you get this pain when you have arthritis in your hip. So looking at the different types, like we talked about, there's many different ways that arthritis can develop. Osteoarthritis is kind of the general wear and tear. Rheumatoid arthritis is an autoimmune reaction where your body actually attacks the cartilage and the lining of the joints. Post-traumatic would be if you had a prior femoral neck fracture or some type of injury to this either hip or even a multi-ligament injury to the knee, and that's changed your kinematics and how your knee moves in space. So you've developed this kind of malalignment syndrome, and the knee is not moving how it's supposed to in space, so you can get this post-traumatic injury. Septic arthritis would be an infection of the knee, gout, a flare-up that can cause destruction of the cartilage in the joint. Juvenile is a younger form of kind of autoimmune arthritis that is not very common, but when it does happen, it's very bad. Psoriatic and reactive are two other similar to autoimmune reactions for arthritis. So we'll just kind of talk about kind of the big ones first, which is osteoarthritis. Like we said, it's the main wear and tear, develops with older age. We're not really 100% sure why it occurs. It can be partially hereditary. It's hard to say why some people get it and some people don't. As you develop that osteoarthritis, you get destruction of the cartilage, you develop bone-on-bone arthritis, and with that bone-on-bone, it becomes very painful. You can get grinding, clicking, restriction of motion. Some people may come in with a flexion contracture of their knee and they can't get their knee all the way straight anymore. They may not be able to flex it all the way down. Part of the treatment algorithm is one, making the pain go away, but also trying to restore function and mobility and giving you that quality of life back. And usually this takes a long time to develop. It may develop over many years. You may see it and it may rapidly advance as well. So it's kind of your general wear and tear with osteoarthritis. Rheumatoid arthritis, this is an autoimmune disease. Your body actually is attacking the lining of your joint. So the lining of your joint is called the synovial membrane. And for some reason, your body decided to make antibodies against that and attack it. And this causes this insane inflammatory reaction. And when all those inflammatory mediators are always in your knee and you're always getting swelling, what ends up happening is you get destruction of the joint. And there's a very classic x-ray with this. You usually get destruction of the joint symmetrically. So it's both on the inside, the outside, and behind the kneecap. So there's usually a clear picture on x-ray of a rheumatoid arthritis patient. You may also have symptoms of other symptoms of rheumatoid arthritis where you have arthritis in your hands. That's very classic. Pain, stiffness, and sometimes over time it can actually even get so bad where the deformity gets so bad in the knee that your nerve fibers actually die and you have this very neuropathic type joint that you're walking on that's very painful. Post-traumatic arthritis, this is where you have an injury to the knee. There's a couple different ligaments in the knee, your collateral ligaments. You may have heard of your ACL, your posterior cruciate ligament. All these help your knee undergo the normal motion. So there's a lot of complex motions that the knee undergoes. When you flex it, it actually rotates and it rolls back a little bit. And when one of these ligaments is injured, the knee doesn't actually properly work. So the other things that are in the knee, like the meniscus And the cartilage, if the knee's not rotating in the right anatomic alignment, you're going to get destruction of the labrum, or sorry, destruction of the meniscus and destruction of the cartilage over time, and that's going to cause your joint to wear out. And so you may see a very young patient who had a multi-ligament or a sports injury to their knee, and they have an early arthritis in their knee. And this could be an indication to talk about doing a replacement in a younger type of patient. So like we talked about, the main symptoms are pain, stiffness, swelling, and arthritis may be a stepwise progression where you're having a really bad day, it flares up on you, your joint's swollen, and then you get a little bit better, and then you have another bad day, but it's a little worse than your previous bad day, and then you get a little better, and then eventually you find yourself at the point where nothing's really helping you anymore. You can get clicking, locking, snapping, grinding, popping, weakness, instability. Over time, as you get the arthritis, your muscles around the joint are actually going to become very weak. They can become atrophied. So one of the things we do to combat this is doing physical therapy to strengthen those muscles up. And if you do need a replacement down the line, then your muscles are nice and strong. But you can get quad atrophy with bad knee arthritis. And some people who have these arthritic changes, it can definitely be affected by the weather and as the barometric pressure goes down. So risk factors, we don't really know why osteoarthritis happens. We know why the other arthritis happens, but a lot of different factors can play into it. Older age, if you have family members who needed an early joint replacement, previous injuries, being obese. For every pound of weight you lose, it takes about 8 to 10 pounds off the joint. So that can be one of the modalities to try and ease some of the arthritis pain. Different deformities around the knee, metabolic diseases, genetics, and if you're an athlete or repetitive stress over time on the joint can definitely cause wear and tear changes. X-ray is usually diagnostic for arthritis. We don't need an MRI to go look at the soft tissues. We can tell that the main soft tissue that we're looking at is the cartilage and that it's completely gone when the joint space has been destroyed. In this patient, you can see he's developed cysts in the femoral head, cysts on the socket side. That bone has a very classic sclerotic appearance, which is a very white appearance, which we talked about. And that's that bone on bone is pressurizing the bone and making it very hard and painful for the patient. So the first line treatment before jumping into anything surgical is always conservative treatment. What can we do to kind of manage your pain and your symptoms in the best possible way? And the first line treatment, like we talked about, is a physical therapy regimen. They have targeted therapies to strengthen the muscles around those joints. And it's not only for getting stronger, but it's also for maintaining your flexibility and preventing the joint from getting stiff. If you do end up needing a knee replacement down the line, you want your joint to be as supple and as flexible as possible so we can get the best range of motion out of it after surgery. But it can also help relieve some of the pain by strengthening up that joint. Anti-inflammatory medications, there's a whole host of these. We definitely want to avoid any narcotic type medications. Those actually can have a reverse role in making the pain actually worse. So basic anti-inflammatories like Tylenol, ibuprofen, ice therapies where you're icing your knee 20 minutes in the morning, 20 minutes at night. It can help bring down that swelling and give you symptomatic relief. So as we talked about, the cartilage destruction causes swelling. The ice therapy kind of combats that. Injections, there's a whole host of these. The four main ones that are out there would be a corticosteroid injection. They have gel injections. They have PRP or platelet-rich plasma or stem cell injections. The kind of gold standard and one that I think works the best is the corticosteroid injection. The other ones are things that you can try. You're not burning any bridges with them. It may help delay surgery a little bit. And it is an option. Weight loss, like we talked about, for every 8 to 10 pounds you lose, or for every pound you lose, it takes about 8 to 10 pounds off the joint, which can really do wonders for your arthritis. But that's not always possible. Sometimes you're functionally limited by the arthritis to actually go out there and exercise. Bracing may provide a little bit of symptom relief. It's not going to provide any treatment. It's not going to cure the arthritis or make your cartilage regrow. The cartilage in your joints has a very poor blood supply. It's developed when we're very young. And because there's no blood supply there when you're older, it doesn't heal very well. And that's one of the biggest problems with arthritis, and why, once that cartilage is gone, there's no getting it back. There's only preventing it from disappearing sooner and getting destroyed sooner. Aquatic therapy, low impact things are great on joints with arthritis, things like elliptical, stationary bike, anything where you're not pounding the ground can be a very, very good conservative treatment. And then those are kind of the mainstays of non-surgical treatment, and we really want to exhaust those, especially in the younger patient. But then it gets to a point where this is really affecting your quality of life. Your day-to-day living has become very difficult. Things like going upstairs, going for a walk, playing with your grandkids, all of those things can become very difficult for you. And really what hip and knee and joint replacement surgery is all about is restoring your quality of life and giving that back to you. So it can restore your mobility, and a lot of people with these arthritic symptoms may also have disruptions with their sleep at night, so it can help take care of that. But the number one goal is improving your quality of life, getting your mobility back. So a couple different types of surgery. You have a couple that are not joint replacement surgeries. Those may be arthroscopic, which can go in there, take a look, see what's going on, see how bad the arthritis is, maybe do a little cleanup. It's not going to cure the arthritis, but it is a less invasive treatment. Joint realignment surgery would be for the very, very young patients, and that's a very reserved procedure, but it is a procedure that's out there. And then kind of the gold standards are either hip replacement on the hip side, which is one of the most successful procedures in all of surgery in the last 100 years, and then partial knee replacement or a total knee replacement. And not everyone's a candidate for a partial knee replacement, but if you're on the younger side, it is something to talk about. So hip replacement surgery, best surgery in the last 100 years. There's many people who have written articles saying this. Patients are extremely satisfied after surgery. It's upwards of 95% of patient satisfaction. The implants we have now are very good. The newer ones are lasting 25, 30 years. The issue with ones in the past was, you can see on this diagram on the right side of your screen, that the plastic piece that goes between the ball and the socket would wear out. But over the years, a piece called the polyethylene, we've been able to make very, very strong, so it doesn't wear out anymore. And surgery takes about an hour. And with newer procedures, newer surgical techniques, enhanced recovery after surgery, different medications and injections we can give you, some people are even leaving from a surgery center or the hospital from a same day, 2 to 4 hours after the operation. Most people are up and walking with physical therapy later that afternoon. Many go home the same day. Many, the average length of stay, I think, for the hospital is about 1 day. So it's really a in and out, quick procedure. We want to get you home. You can recover best at home. And the goal of all these procedures is getting you back to your normal life, getting you back to restoring the quality of life that you had before this arthritis was so debilitating. I do a direct anterior hip replacement. I like this approach because it's a small incision. It's usually about 10 centimeters in length. It's minimally invasive. I don't have to detach any of the muscles. I actually do the surgery between the muscles. There's a little less bleeding, less pain after surgery. You actually have a lower dislocation rate, so the hip is actually more stable from the front approach because you're not taking those muscles off. And patients have a quicker recovery and better function. Knee replacement surgery. So this is a great procedure. No muscles are cut. The arthritis, we go down to the joint, we take out the arthritis. As you can see on this image on the right side, it's a very arthritic joint. We go there, we cap the thigh bone, we cap the shin bone, and then we put a polyethylene piece in the middle, which allows that knee to articulate and bend back and forth. This helps with decreased pain. And one of the biggest things is that removes your pain, but it also can restore your function. So if you have a very stiff knee, if you can't get your knee fully extended, if you can't get your knee fully flexed, this is a procedure that can help recover your range of motion. The other thing, if you have a pretty bad deformity with we would call this a valgus alignment or a knock knee type deformity, as we put the knee replacement in, we actually realign your bones. We actually straighten out your leg as well. So that can actually help aid your walking. This patient will obviously need had a double a knee replacement on both sides to straighten out that knock knee alignment. And doing the joint replacement, because that joint becomes stiff and not mobile anymore, actually can help your other joints. So it can actually take stress off your hips. If you have a knee replacement, it can actually take stress off your lower back and kind of preserve some of those other joints from wearing out as quickly. So I just wanted to say thank you for everyone for joining. I'm going to go through the Q&A right now. This is my website. I have videos of the cartoon videos of the procedure online. I do education through my social media. You can follow me on Instagram, Facebook, or Twitter. If you have any questions after this is over, you can send me an email, and my office number is listed there. So I'm just going to go through the Q&A. I'll go through the Q&A panel real quick and see what questions we have. So Annie Killerin asked, is there any downside in delaying hip replacement surgery, notably damage that potentially complicates the surgery? So the first part of that question, for me, there is no downside in delaying the hip replacement surgery. The surgery does not become any more difficult for me by waiting longer to do the procedure. The biggest issue with delaying the surgery is that you're going to have to live with those pain type symptoms and that decreased quality of life. And if you're okay with that, it doesn't make our job any harder. So a lot of the times, we try and do things to delay, whether it be a hip injection, which we sometimes do, medications, more PT. But the ultimate answer to that question is no, it does not make our job any harder delaying the surgery. The next part of Annie's question is, do you anticipate a less invasive procedure for the hip becoming FDA approved in the near future? Stromal cells or HA injections? So I'll answer two parts of this. So from a non-surgical perspective, it sounds like you're asking about more injection type things. It's questionable whether hyaluronic acid, it does provide relief for some patients, but usually it's anywhere from 30 to 50% of patients may get a little bit of relief for 3 to 6 months. Usually by a year out, they're still having issues. And stromal cells or any type of stem cells, it's not going to regrow the cartilage. I mean, that would be the ultimate discovery if we could figure out some way to regrow our cartilage. But the bottom line is cartilage has a very poor blood supply, and you can't get it to regrow unless you figure out a way to restore the blood supply to that cartilage to get it to heal. So as far as injections, I don't think there's anything in the near future or radar that would be less invasive. From a surgical perspective, I think the anterior approach has become very popular in the last 5 to 10 years, and I think from a surgical approach, that's very, very minimally invasive. The next question, one more from Annie. Complications of anterior approach hip replacement. So the biggest complications are surgeons who may not be fully trained or have as much experience. So there's a learning curve to the anterior approach surgery. So, and there's been papers published on this, and a surgeon has to have at least 50 to 100 of these procedures done to become very proficient. And so the complications occur when you're not proficient at getting a good surgical exposure. The biggest complication is a risk of fracture during the procedure. But one, there's things that have to be noticed ahead of time, right? You have to notice whether or not the patient has good bone quality so that you can take that extra care to make sure there's no fracture. The second part is you have to be able to perform a good exposure and a good release so that you can see all of the bony anatomy that you need to be working with. And with that, that prevents any type of intraoperative fracture from happening. So I've never had an intraoperative fracture, and that's probably the biggest one. It's much less than 0.5% if you're looking at all surgeons that do that approach. The other kind of complication, or I wouldn't call it a complication, but symptom of anterior approach, there are some nerve fibers that run over the anterior part of your hip. Some people may get a little bit of anterior thigh numbness, which you can kind of avoid that by shifting your incision a little more to the outside. So I move my incision a little more lateral to try and avoid those nerve fibers. But sometimes you can get a little bit of anterior thigh numbness. On the flip side, the pros are you have a much more stable hip, so dislocations much less. Ralph asks, if you have a candidate for both knee and hip replacement, is there a strategy about which to do first? Yeah, so I think this is a very important question, and that you do the hip first. So hip procedure is one, it's a more successful procedure. It's an easier recovery than knee surgery. If you have hip arthritis, it can cause referred pain to the knee. So by doing the hip first, you can actually relieve a lot of the pain on the knee, and you can get rid of that referred pain to the knee. So there is a component of pain that's generated from the hip that goes to the knee no matter what. So I think you treat all that, and then you see how the knee is doing. And you probably give it, I would say, about 3 to 6 months as you kind of rehab the hip and see if it gets better over time. If that knee pain gets better over time, you know, maybe we have a couple more years before we have to replace it, or maybe the hip replacement didn't provide the knee relief that you were looking for, and then we move on to a knee replacement. But I definitely say do the hip replacement first. Okay. So it looks like those are all the questions from this talk. I want to thank everyone for joining, and this has been a great session. And once again, thank you to John Hopkins for sponsoring this talk. If you have any questions, my email is listed here. You can feel free to send me an email at any time. Thank you, guys. I hope you have a great night.